So thanks everybody for joining this session. Just want to introduce myself. My name is Tom Swain, from Virtual. Thanks for joining up. This session is actually titled Using VERT to Teach the Principles of DiBH, and it's actually around the breast treatment. So I'm going to introduce you in a second to Angela Williams. Angela is the Clinical Learning Facilitator at Mount Vernon Hospital, which is just outside of London in the United Kingdom. We're really lucky to have Angela today because she's already presented and spoke before on one of these webinars. So back in February, Angela presented the 3.1 pelvic training materials, and you can actually find these on our YouTube channel. So if you go to type Virtual Limited into YouTube, you should be able to find a list of all of our videos that we've uploaded. So Angela's going to talk today about some continuing collaboration work between Mount Vernon and Virtual. And we're looking at the DiBH technique and how Angela's implemented a presentation. Mount Vernon is a variant site, so it's focused around the variant RPM system. But we are looking at different avenues of creating a kind of similar presentation with some Electa content in that. So I'm going to pass you now over to Angela, and I'm going to give Angela control, and then there you go. I think you should be in control around.
Yeah, thank you. That's great. Thanks, Tom. So hello, everyone, and good morning to some of you, and good afternoon to some of the rest of you. So today, what I'm going to look at, as Tom said, is using VERT for DiBH training, or Deep Inspiration Breath Hold, and we're going to talk about how we've actually implemented that here at Mount Vernon. So VERT was actually introduced here quite a while ago now, in 2009, and we've been using it to create training material throughout this time. We created the DiBH training as this technique was being introduced within the department, and we recognised that there was a training need for this. So the aim of today is to have a look at the training I've created and hopefully give you some ideas on how to create VERT materials in your own department or educational institute. So we've used VERT for a wide range of treatment sites now, and we've found that the training has been really successful, particularly when we've used VERT to look at visualization of techniques and anatomy, and also for problem solving as well. And the evaluation of forms that we've done have backed this up, which has been really useful. So in terms of background, what we've done is we've created the workbook and the VERT session, and the main themes within this session, we're looking at increasing the awareness of what DiBH was and why it was beneficial. And also within the session, we've looked at technique review and protocol review, some setup scenarios using VERT to look at differences with setup and problem errors. We've also got some questions within a workbook to support professional development. And we've also looked at side effects, support services that are available, and the holistic care approach within the tutorial and the workbook as well that's involved with it. So looking at the background, to begin with the session, it involved getting background research and information onto PowerPoint and then into the virtual presenter, as you can see here, which we saved as a JPEG. And you'll see quite a few of these over the next few slides before we get onto the more VERT-based content. Obviously, you also need to then identify a suitable patient and get them exported to VERT as well. So to begin with, we're really looking at what DiBH is and why it's useful. And we've also got on here some JPEGs just of the imaging equipment and the breathing apparatus that we're using. So I'm sure this is familiar equipment, probably very similar to what you're using within your own departments. So within this session, what we're doing is we're using it for staff and also for student training as well. And again, we've got a picture here just of our apparatus that we use for those people that haven't used this breastboard before. And we've got the patient monitor screen here, which is where the DiBH screen, which you can see on the next slide, is situated. So this is what the patient can see on that monitor. It is the variant-based solution, as Tom was saying, and we are working on trying to get some Electa data into here as well. But obviously when the patient breathes, the yellow bar moves up into the blue gating window here and then goes green, so the patient is aware when they're holding their breath within the correct area there. And then we can proceed with the treatment. So with these tutorials, we've also been looking at the CT process and the treatment process. So what I've been doing is really asking staff and students what their experience has been in CT, if they can explain the procedure to me, and then filling the blanks in for them if they're unsure of any of the steps. Initially, when we introduced DiBH at Mount Vernon, we did have a set criteria because we thought the patients would take longer to treat. So we didn't offer it to all patients, but now it is the standard practice for left-sided breast patients if heart is included within the field. So we just go through what happens in CT and just double stressing really that the patients obviously have to be able to hold their breath for quite a long time, building up to 30 seconds. And the tendency to do that when you do hold your breath is to actually arch your back and lift your shoulders off the breastboard. So this is one of the things that we try and stress during the training, is to ensure that the patient is as relaxed as possible with their back flat against the breastboard and their shoulders not lifted. And this does help to eliminate setup errors when the patient starts their treatment. But the other thing that sits alongside this is we have a workbook. Sorry, Tom, is it down the bottom, the workbook?
Yeah, it's just the yeah.
Ah, thank you.
I just pass the control off over to you again.
Yeah. I'm just going to try and scroll down to the next page.
Sorry, I'll move that chat box out of the way.
Yeah, thank you. So with the workbook, what we've done is we've set some questions within the workbook, and on here we've just got a brief overview as to what is contained within the workbook. And then if I just move down to the next page, we've got on here some questions, and we're also looking at the advantages and disadvantages of DiBH. So when we're explaining about the CT process and talking about the patient having to hold their breath for a long time, and also the fact that the patient has a free breathing scan to begin with, and then they have a scan in breath hold afterwards. So we talk about the advantages and disadvantages of DiBH. Of course, the obvious advantage is the fact that we're wanting to eliminate cardiac tissue within the field of radiation, which has been shown to cause significant side effects later on. So we want to reduce those as far as possible. So the staff and students can write that in the advantages and disadvantages box here. And we'll come back onto here again a bit later. So we have another JPEG here, just of the gating window being sat in CT. So when the patients are at their comfortable breath hold, then the window bar is set on either side. And then we go on to talk a bit more about the DiBH treatment. And again, we put it to the staff and the students as to how they actually set these patients up to begin with, to ensure that they're aware of the protocol. When we first started doing DiBH, we did an audit and we found that it was taking an extra 5 to 10 minutes per person to actually treat the patient with DiBH, whereas now we're finding that it's actually only taking a few more minutes, 2 to 3 minutes longer for each patient. So the time taken to actually treat these patients has increased significantly over the past year whilst we've been getting used to it. So with VERT as well, you can now import videos into VERT. So we took a video of the patient actually going into breath hold, which I'm sure a lot of you have seen before, but I'll just play that for you now. And you can see the yellow bar at the top there. about to go into the blue box when the patient takes their breath. And you can see down the bottom here, the patient takes a big breath in and there's a peak of breath before the breath stabilises within the gating window here and the treatment is actually on. So it's quite useful for people that haven't seen patients having treatment in this manner before, for them to be able to visualise the technique and how it looks from outside of the room. So outside the room, of course, we have the radiographers out here that are talking to the patients over the intercom and encouraging them and telling them when they should be taking their breath. So the next part here is looking at the same patient scan, one in deep breath and one in free breath. And again, this is a question that we put to attendees to say which of these is in free breath and which is in DiBH. So we then find out that this is the side where we're in DiBH, and just asking why do they believe it's so that that patient is having their treatment in DiBH, and they're able to then reason that there's a more difference here with the back border of the field to the heart. There's a greater area of tissue here of lung being treated, whereas on this side there's a much smaller distance between the heart, and this is just the central axis slice. So obviously when you go on other slices you do get more cardiac tissue involved on the free breath slice. The other thing that staff sometimes say, and students, is that the chest is obviously more inflated here, so the patient is obviously in a deep breath. So we have some discussion around this image, and again this was done in VERT by taking a screen grab of the patient in free breath and then in DiBH, and then putting it into paint and then saving that screen so that you can see the two side by side with each other. We've got another similar image here, and this is a question that we ask attendees to find out if we've gone sup or inf to the central axis. So looking at this one, we can see that we've got quite a lot of liver here, so we've gone inf to the central axis. And we can see again on this one that the lungs do look like they're more expanded on this one, which is the DiBH, and you can see that we're not quite touching the heart on this side, whereas in the free breath we have got some heart included within the field here. So we have quite a lot of conversation in regards to this image and talking about how obviously it's not just the heart which is in a different position when you do the deep breath, but also the liver and other internal organs as well are also in a different position. And this is a useful image to come back to later when we're looking at the amount of lung in the field for DiBH and also for free breath as well. So then we go on then and have a look at some of the treatment scenarios and setup scenarios. And again, these are just a guide really, so you can tailor them to what problems you find you have within your own department in relation to setting up patients that are having treatment to their breast. On this patient, we can see that, that the field is falling just inside the edge here. So it's about a centimetre probably inside the field here. And then if we have a look and go around to the other side, we can see that we're falling over in this dimension. So we're inside with the light beam on the medial and over with the light beam on the lateral. And again, this is a question that we pose to people as what has happened to this patient and what would they do in this situation. Now, I think our technique at Mount Vernon is quite unique in that we have a small amount that we can move the couch by, a tolerance that we can move the couch vertically by 5 millimetres, and we can also move the gantry by 1 degree. And I have had sort of students saying, well, actually you could move the bed up or down, or you could move the gantry. And it's useful on VERT to be able to say, well, okay, if we move the bed on this side and we drop it, then it's actually not going to help. So we get the patient, the student, to have a look at that, and also the staff members as well, to find out what they think's happened to this patient. And of course the patient has rolled. So it's just encouraging people to realise that in this situation they should be resetting the patient up again and not trying to adjust the field to fit. We've got another scenario here on the same breast lady where the medial edge is falling over the edge, the light field is falling over by about 8 millimeters, and we've got the same on the lateral edge as well, where it's falling over by 8 millimeters. And with this patient, we use the scenario that our anterior pin is also off by 8 mils. So our technique here is to align to our tattoos at a set distance and then drop the bed and move across to the anterior isocenter. So we say in this scenario that the pin is off by 8 millimeters, and then when we look at the medial and the lateral, we can see it's also off. So again, it's just checking that people are aware of the tolerance so that they know how much they're able to manipulate the bed. We've also got on here a couple of dose distributions as well. So this is the first one where we had the 8 millimeters off. So you can see that with the 8 millimeters off on height, we're actually missing out a slither of breast tissue here, which is not receiving the correct amount of radiation. It's very cold in this area. And if we scroll through on the CTs inferiorly, then you can see that we actually begin to, sorry, gone a bit too far, we actually start treating through the heart. So obviously in this technique what we're doing is trying to avoid the heart completely, and now we've completely negated that by not being correct on our distance. So we need to ensure that we're spot on with our pins and our treatment to ensure that we're not treating any underlying tissue. So that's obviously the one where we're 8 millimeters off on the height. So then we've got another distribution where this is how it's planned. So you can see that the dose distribution is perfect over the breast tissue. And then again, when we move inferiorly, you'll see that we're not touching the heart. It's just skimming the top of it. So it's really just going through the underlying importance of the technique, the tolerances that you have and why they're set as such, and ensuring that we're not treating any underlying tissue that we want to treat. So on here we've also got some questions which you may have seen as well in the workbook. So there's a space for this within here for people just to circle the answers that they would think are correct. So within here we've been looking at what the maximum lung depth is for DiBH. And again, we've been asking staff and students what the lung depth is for ordinary breast treatment. And we quite often go back to the central axis slice and say, yes, it's 2 centimetres for a normal breast patient, the maximum amount of lung. And you can see in here the amount of lung is very small. But when you look on the same slice, on the same patient in DiBH, the lung is actually, there's more lung included within the field. So then that starts people thinking, well, actually, there's probably more lung allowed then within the DiBH treatment field, which is correct. It's normally 2.5 centimetres. That's the maximum amount involved. With this question as well, we have quite a talk around voluming because of breast treatment here is definitely going along the line of heart and lung being volumed rather than actually going on a depth in centimetres. So that's another talking point that we have within this session. And then we also have a look at the tolerance for heart as well from the fast forward trial. So again, staff can circle the answers that they feel are correct within these sessions. And we have ones also down for the organs at risk for lung. We do sometimes use cards for these, depending on how many attendees there are at the session. So we do give out staff members and students A, B, C, D printed on individual cards, and they can hold their card up as to which answer it is. And this works quite well for the people that don't really want to actually say that answer out loud. They feel more able to participate if they've just got a letter to hold in the air. So that we've found has been quite useful. Since I've typed up this evaluation, I've actually done this session now with more staff and more students. So we've now had 50 attendees, and all of them have found that the session has been really useful and felt that VERT has aided their learning. They find the main thing that they are finding beneficial is looking at the scenarios and the visualization aspect to be able to see really clearly what it is they're treating and why it's so important to stick within set tolerances. And it's the screen grabs of the DiBH the DiBH central axis and in free breath that people find useful as well. I think having it side by side like that is quite useful to help people understand the importance of it. We've also added some talk about side effects and also about support as well mechanisms for patients while they're on their treatment. So we've included within here information about the Linda Jackson Centre or Macmillan Support Centre, and also we've been looking at the skin side effects and their management from the Society of Radiographers to ensure that we're using the up-to-date information. So that is really the workbook and the presentation in a nutshell. I'm more than happy if anyone's got any questions to talk through those, or if anybody wants to email me at a later date, then that's also fine. So thank you very much for listening. I hope it was useful. As I said, we've certainly found it really beneficial, so hopefully you'll find it beneficial in maybe working things out for your own department.
Brilliant.
Thank you for
so
listening.
much for that, Angela.
That's okay.
Great. I've got the chat box back up now, so if anyone has any questions, then feel free to jot those in. Really, I think it's really great, actually. Especially the part I was looking slide 19 and 20, where we actually have the error, pin the 8mm error.
Yes.
I think having the dose distribution and seeing that on the transverse slice, you can actually see the difference, because I think there is especially when you're really busy, radiography background, when you're really busy in the treatment room, there's that temptation just to kind of drop the 5mm, but then you're actually seeing what that effect does.
Yes.
And I think that's quite a powerful thing to be able to see that.
Definitely, and I think, that's definitely rung true with, people that have come to speak to me after the session as well. Yeah. Yeah,
brilliant. And Lisa's just put, I agree, great way to visualise this on the...
yeah.
And I think in the nature of these things, there is going to be a certain element of kind of PowerPoint while you're explaining the concepts, but then you've also got that really great input where you look at the treatment scenarios and you have the kind of CT slices side by side. So, yeah, really good job with that.
Thank you.
No problem. What I might do is just take people's audio off as well. So I'll unmute everyone, I should say. So if anyone wants to ask some questions, then feel free to go ahead. Keely has put very useful presentation. Would like to use something similar for our students. Well, on that note, Keely, we're actually looking at kind of including this with our next release of the software. So that would be for people who have software support, which is luckily you're one of them. Everyone in this meeting is. So we're kind of working at the moment with Angela and internally to be able to build this into a session that then can be sent out with our new software, so that it can be used by everybody really. She put great with these smiley face. That's a good sign. Captain Hill put thank you, really good. So nice feedback there. I think it's always interesting to know as well, Angela. I think people really want to do these kind of training materials and put these kind of sessions together. How long on and off do you think it took to kind of build this?
It probably took, I reckon, about 6 or 7 hours, I would think, because there was just the whole importing it into VERT, getting the patient anonymised, getting all that through, And then really it's just the research behind it, and there's a lot of CPD questions which I didn't actually show at the end. There's a lot of continual professional development questions within the workbook. So there was quite a lot of research that went into those to make sure that we had the most up-to-date information as well at the end. So yeah, that's probably roughly the amount of time I would say.
So once you, I know it's a bit of effort to get through, but once you've done that, then you've got that session for a long time. Then, I mean, how many times have you rolled it out now? Do you think with staff and with students?
Yeah, well, lots, and we're doing it to all the new staff as well that start. So that's what I was saying. We've had 50 now, 50 attendees. So it's quite a lot of people that we've used it for, and then obviously we're also using it for posters to go to the education conference in November, and also presenting it with the results in January at the Society of Radiographers conference. So you do these things, and then kind of you find other avenues to use them for. So yeah, but I mean,
quite a high number of people you've presented and given this
yes.
to. Robin's
Yeah.
come back with a question. She's put very streamlined indeed. Thank you. This sits really well in our level 2 teaching sessions.
Yeah.
Speaking of time, how long does it on average take to deliver the session to students?
It depends how in-depth you want to go with it. I think the actual session itself probably takes about 35 minutes. I have got some anatomy and things within the workbook as well, which I tend to just let them read. So if you actually went through all the anatomy with them as well, and then every CPD question at the end, it would probably take a good sort of hour and a quarter, but I tend to just pick a few most pertinent questions from the questions I've created at the end to go through. So it probably takes about 45 minutes with some sort of extra questioning in there as well.
That's really good. And is it just radiographers you've done this with, or is it any other people as well? Or is there any plans in the future?
At the moment, it's just with radiographers that we've done this one. I know that we've got some new registrars at the moment, so it might well be something that we roll out to those within the next 6 months. But at the minute, it's mainly just been focused on the radiographers.
Oh, brilliant. I think it's a really great session. I think it explains everything really clearly. We should be nice and proud of that.
Oh, thank you.
Any other questions from anybody at all? Oh, hold on. Oh, here we've got Robin's back again. He's put, as you put so much research into it, would it be worthwhile to cite some of the points you highlighted, such as in-depth coverage for the DiBH technique compared to normal technique?
Sorry, say that again, Tom. I didn't quite hear the first bit.
Sorry. So, as you've put so much research into it, would it be worthwhile to cite some of the points you highlight, such as in-depth coverage of the DiBH technique compared to normal technique?
Yes.
I'll take you off your microphone mute off there, Robin. So if you want to have a little chat with Angela, then.
Hi, Robin.
Hi, Angela. Can you hear me?
Yeah, good. You okay?
Yeah, absolutely. We meet again.
We do.
Yeah, I mean, I was just looking at your presentation there, and yeah, I mean, you know, you're clearly aligned all your visuals and development work with theoretical underpinning publications and so forth and protocols. So I'm just wondering whether it could prove useful to cite some of these things that you mentioned, such as the lung coverage that you were mentioning, where there's a 2 centimeter depth and there's a 2.5 centimeter depth, and
Yeah.
Just so that potentially you could signpost students or attendees or participants to read further into this if they wanted to.
Yeah, sure. A lot of those, the 2 centimetres and 2.5, is literally our local protocol.
Okay, yeah.
Now, I'm sure that there are other guidelines, and the fact that we're going more now towards voluming, I think that's going to be the new sort of standard thing, really, that's coming through. And certainly from sort of like the local breast group that's doing the quits, That's what they're talking about at the minute. So I think that will soon be superseded. But yeah, it's definitely worth mentioning really to people to look at their own local protocols and find out what's happening locally. Some of the stuff as well is also from trials. So the last questions that were on there with the actual voluming was taken from the Fast Forward trial. So that's another good place to signpost from. And I think at the end of the workbook, it's got the references at the end there. And it's also got some further reading as well, some different trials and things that have been happening and sort of most recent papers. So there's a few bits at the back there that might be useful.
That's fantastic. Thank you.
Yeah.
Yeah, really comprehensive. Okay, so any other questions from anybody else? No? Okay, so as long as there's no more questions, we'll just bring that meeting to a close there and stop the recording.